joining us for today's webinar, Ask the Author Q&A, the Body-Based Obsessions Workbook, CBT Skills to Manage Anxiety and Intrusive Thoughts about Your Body and Brain. My name is Jolie Busby, and I'm the Education and Training Manager at ADAA. And so with that, I'm very pleased to introduce our moderator for today, Christopher Weston. Christopher's professional experience extends beyond the walls of his therapy office. As the former Deputy Director of the El Dorado County Public Health Division, he managed countywide public health programs in addition to starting the largest primary care organization in the county. In his transition into the mental health field, Christopher has worked directly with delinquent, high-risk youth and individuals struggling to secure stable employment while overcoming obstacles such as health, housing, and childcare. Welcome, Christopher. Thank you for moderating today. I'm going to turn the presentation over to you now.
Great. Well, first of all, I'm going to thank the ADA for putting this on. Very excited about workbook, and I want to introduce Molly, the author of the Body-Based Obsessions Workbook. Molly is the Associate Director of the Center for OCD and Anxiety at Sheppard Pratt in Towson, Maryland. She specializes in mindfulness-based cognitive behavioral treatment for OCD and related disorders, and in treating PTSD with cognitive processing therapy in both residential and outpatient settings. Molly Schiffer is the author of the Body-Based Obsessions Workbook and a frequent presenter at the annual conferences of the International OCD Foundation and the Anxiety and Depression Association of America. So Molly, first, thanks for being here. Totally excited. Read your book. And I just want to first put this out there. What inspires you to write the Body-Based Obsessions Workbook?
Well, thanks for having me. I'm excited to be on talking about the book. And it's kind of a very large, broad question because there's so many factors, I think, that went into writing this. I think a lot of my own personal experiences, I talk about that fairly frequently in the book. I really do like to blend those two together. And, I originally intended to write a memoir and before I wrote this book and wasn't ready for that. So I started thinking about sort of another book I would be interested in writing. And I have written about health anxiety in the past and mental health anxiety in the past and had a lot of people respond to that, feeling like the information I provided was coming from a little bit of a different perspective than what they'd heard before. And so it got me thinking more and more sort of about my experience growing up, being an anxious person myself, but my mother, and I talk about her in the book, also had OCD and a lot of challenges. And so I think I originally the title was going to be called How to Have a Body When You Have OCD. And then that brought into body-based because I really wanted to write about all the different ways that a person can be anxious about their physical body and why that's hard. And also to add onto other literature about health anxiety, where it's mostly talked about from the perspective of the core fear being of being sick or dying. And there's a lot of other fears people have related to body-based obsessions. So that's a very big answer, but those are the highlights.
What I really appreciated was the variety of body-based obsessions you talk about. It wasn't just a limited amount, but you did the whole gamut, and it was first place I've seen that in a book. which is phenomenal. I personally suffer from hyper-awareness OCD,
Oh,
and so I have personal experience with that. So I've done research and all kinds of stuff, and it's awesome. I want to ask you, first of all, kind of grounding the audience in what this actually means, body-based obsessions. What exactly are they? What 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 does that encompass?
sure. Well, I think in order to describe that, I first need to kind of define what I consider an obsession.
Great.
And I usually define that as being a thought, image, or urge that is repetitive, unwanted, and intrusive. And along with that, it arrives with a whoosh of anxiety, which is the product of the fight flight response. So body-based obsessions specifically are when a person becomes anxious about any part of their body, whether it be, becoming aware of some like, breathing process or blinking, or whether they're worried about their mental health and their diagnosis and whether it's accurate. So the body based just means there any part of your body. And it's interesting because a lot of times people think of the general things that people write about, but really there's so much a person could worry about related to their body, and there's something very painful about that, I think. And to have your body feel like something's going on and you don't really have an answer, and no one else has a really solid 100% certainty answer either. So it becomes an obsession when it's all you can think about, focus on, um, and it's very painful and creates a lot of suffering. So it's just body based means any part of your body, any process in your mind, in your body, the physical appearance of your body, the way your body works, things that could happen to your body, etc.
Right. Um, totally agree with you. And what's interesting, um, and question I have is what makes particularly these body-based obsessions feel different from other types of OCD? So, for example, like contamination OCD,
Hmm.
or the relationship OCD. What kind of is the difference between that?
So I think there's two answers. One is there's not necessarily a difference in the sense that there's a process that
Hmm.
goes on, whether it is relationship themed, whether it is contamination themed, whether it is some part of your body themed. Um, the process of the anxiety is the same, the urgency is the same, the need for certainty is the same. Um, but what is, I think, different is that when we think about like OCD, or we think about generalized anxiety disorder, we think about how thoughts sort of show up and they're painful in and of themselves. When somebody is focused on something related to their body, the actual sensation or whatever it is they're experiencing physically is almost like the obsession, and it happens repeatedly because it's happening on your body, and so you're noticing it, and there's something about that that feels, I think, and this might be subjective but very painful, um, for a wide variety of reasons, but especially because we have one life, and we feel a sense of responsibility, to care for it, and there's a lot of fear around keeping it safe, I think. So I think those are the general differences. Is there's just, I think, a lot of uncertainty that's very inherent in things, that anxiety about your body, similar to OCD too. But I think what separates the book from other books is it was written really to encompass OCD, generalized anxiety disorder,
Hmm.
people that don't have a diagnosis, it's anyone that is experiencing suffering as the result of the way they're relating to their anxiety about their body.
Mhm. What I found in my particular manifestation is the hyper awareness OCD, and for a long time, and I focused on my blinking,
Mhm.
and the challenge that I had, and I always compared it to other types of OCD, is because you're always blinking,
Yes.
right?
Yes. Right. Right.
And it's something that you have to do all the time, and
Mhm.
it's like I can't forget about it. It's like I have to always have that, right?
Right. And I think part of what makes that painful for people, like thinking about your blinking, when you first say it out loud does not sound like it should be that painful.
Mhm.
But I
Mhm.
think that in my experience with my own hyper awareness symptoms in the past and with working with patients is that they know they're not really supposed to be aware of it. And so
Mhm.
it's sort of like when you're having trouble sleeping and you think about everybody in the neighborhood with the lights off and they're sleeping and you're like wide awake.
Mhm.
It's like you're aware of your blinking. Suddenly you're not sure if you're responsible to figure out when to blink, how often to blink.
Yes.
Can I
Yes.
blink? How should I
Yes.
blink? Like, right? And so
Right.
I think that's what it's this I shouldn't be aware of this thing, and how
Mhm.
will I become unaware again? There's like a
Mhm.
quest to get back to not knowing, and that's where the struggle is.
Right. And the challenge, I think, is also that you lose your enjoyment in the moment because you're so focused on the blinking, and you just,
Yeah.
you can't get out of that, and your moments in your life and during the day, it's just like I'm not enjoying anything because I'm I'm trying to figure out this
Yeah.
blinking, right. Yeah.
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 Well, yeah, and I think that applies to, all the different types of obsessions that, like I mentioned in the book, is there's this sort of I either need to be completely unaware or I need to
Hmm.
be completely focused. And so
Right.
there's sort of this forfeiting of any enjoyment you could get
Hmm.
for this. I need to get rid of it or I need to
Hmm.
focus on it and figure out how to get rid of it.
Right.
And so my hope in writing this was to help those that struggle with that and then miss out on the things that bring a person joy and value and meaning in their life, and to learn that, like, oh, wait a minute, enjoying 60% of like a conversation is better than zero. And it's interesting when you start
Yes.
talking to someone like that, the initial response is like, that's unacceptable. I need it to be gone. And so the work in therapy and the work, I think, if you're working through the workbook, is to sort of recognize that sort of distorted thinking and
Yes.
start practicing, that the being mindful of when your attention is being pulled and bringing it back so that you can experience whatever's available. And that's a much more joyful way to live. And I think people don't know that's accessible all the time, and they can't imagine why that would make a difference, but it does.
For sure. And I think the great part about the book is it's a workbook,
Hmm. Yeah.
and it's for those who suffer from this. And I mean, you have a lot of room in there to have people answer your questions and that kind of thing. On the treatment side,
Hmm.
you talk about CBT.
Hmm.
You talk about exposure response prevention,
Hmm.
and maybe you can elaborate a little bit more on the CBT and the ERP with regards to treatment for some of these body-based obsessions.
Yeah. Yeah. So So I'm trying to think of the best way to describe it all.
Yeah,
I
it's a
consider
lot.
I consider like there's a few main components, right?
Mhm.
There's the psychoeducation, which is teaching a person about the way they're experiencing their anxiety, and
Mhm.
teaching them about the cycle that happens for any kind of anxiety. Sometimes people get really stuck on what kind of anxiety they have. And what I always like to bring back to people is they all pretty much operate the same and can be treated the same, in the sense that, you know, they're maintained by these behaviors, which I'll explain in a moment. They're maintained by these behaviors, and so interrupting it in the same place, um, it is the same for all of them. So psychoeducation in the beginning, just helping them to understand how they're stuck and why they're stuck. Um, with body-based obsessions, I talk a lot about beliefs, and I talk about
Mhm.
thought patterns and how those two kind of um, can be underlying these obsessions. And so there's often a period of time where we're talking about the way a person is thinking about their obsession, not necessarily what the obsession is, but what they're
Mhm.
thinking about. Um, and then exposure response prevention, which is one of the primary interventions that you'll find in OCD, you'll find in BDD, you'll find in most anxiety related disorders, somatic symptom disorders. And exposure response prevention involves two pieces, and I try to make that pretty clear, right? There's the exposure and then there's the response prevention, and both are necessary. And so there's the exposure, which is really identifying things that are triggering, depending on what your particular thing is, and then trying to trigger the urge to do a compulsion,
Mhm.
so that your brain can learn an alternative way of coping, right? We trained in anxiety, you're training your brain to think, right, that this is dangerous and that you need to respond. And so that's what your brain knows. And so what we're doing with exposure response prevention is we're approaching the thing that makes you anxious, and we're responding differently than normal, which means no compulsions. Um, and that's like a very general summary of exposure response prevention, because there's a lot more that goes into
Mhm.
that. But then there's also, okay, so we're dealing with, we're not going to do the compulsions, but then what do we do with that part, with the
Mhm.
mind, right? And that's where the self-compassion comes in and the mindfulness practice comes in. And throughout the book, I try to make those interventions very accessible to people that are aware of mental health, but also for people who are new to really reading about it, or doing any kind of work through a workbook. So those are the main strategies I talk about, but there's, depending on what it is, I sprinkle in things depending
Mhm.
on, what I think is needed, um,
Mhm.
especially when they're body based, because I think sometimes understanding why it's painful, or understanding where the belief came from that drives the compulsions, can be helpful.
You talk a lot about, which I appreciate, and you mentioned the mindfulness,
Mhm.
self-compassion,
Mhm.
and some people can be a bit confused about those terms because they're used a lot. So, uh, as far as mindfulness and self-compassion, how do you incorporate those into your therapy and helping your patients, your clients?
I would say a lot of different ways.
Hmm.
First there's obviously the psychoeducation that goes into it, of like what
Hmm.
those things are. And so with mindfulness, and self-compassion, right? Those are topics that most people have heard those terms, right?
Mhm.
So they sort of have some preconceived notions about what those mean, right? Mindfulness, you see the mindfulness coloring book in the grocery aisle, you see the apps. And so people kind of get this feeling of like, oh, great, there's mindfulness, or like you talk about self-compassion, and what they're hearing is, oh, give yourself a break, which people with these kinds of obsessions typically aren't prone to giving themselves a break. And so luckily, that's not really what those things are about. So I usually start with a psychoeducation about mindfulness, but starting with the idea that they're getting hijacked constantly by the content of their mind, right? And that they're never really present where their feet are. And so when we're talking about that cycle and we're talking about the presence of those intrusive thoughts, we bring in mindfulness as a way of relating differently to those thoughts when they show up, instead of the typical response that a person might have, which is like, oh no, not that again, or go away, or I wish that wasn't happening, or something like that. It's more like, oh, huh, there's that, and teaching somebody how to allow, unwanted thoughts, feelings, sensations, allowing whatever is showing up to sort of be there without any kind of judgment. And I often bring in the idea that our brains are a lot like puppies. They just run hither and yon, and chase cars and do all that kind of stuff, and without training, right? That's what they do. And if I want my puppy to come back to me, I'm not going to scream bloody murder at it. I'm going to be like, come on, girl, come on back. And we have to do that with our minds. So when a person is suffering with the constant intrusion with something about their body or something about their health or something about their appearance, learning how to notice the thought has shown up, notice any feelings, sensations that a person is having, and trying not to judge the presence, or trying not to judge that you got lost. So people have in their mind with mindfulness that you're supposed to be really peaceful and you're supposed to have a clear mind. And they have this idea that there's a right way to do meditation. And so in the book, I talk a lot about ways to practice meditation that you can really start doing early in the process of therapy. I talk about like, toothbrush meditation, and it's just a way of putting your attention on a process, and allowing yourself to focus on that. And when your attention gets pulled, it's bringing it back. And so I talk with people about that idea that their brain, like the puppy, we have to bring it back gently, like, oh, there I go again. So that's kind of how I start to bring it in. I especially bring it in when somebody is struggling with acceptance of having noise in their mind. And I talk about that also in the book, is like this idea, where did we get the idea that our minds should be free of these thoughts, feelings, and our bodies shouldn't make noise, or give us any problems? These are sort of like preconceived. And then the self-compassion piece also has to have a lot of psychoeducation. Um, and I bring that in a lot because there's often a heavy judgment about like, why am I stuck on this? I shouldn't be stuck on this. And sometimes self-compassion for me, I teach like, even if you can get to neutral, that's better than complete judgment. And so sometimes with people, I might have to, teach them about like, identifying the thought, and then how can we move that? How can we move the needle towards neutral? And then teaching them what self-compassion is and what it isn't. Because a lot of times people think self-compassion is this like flowery, like, way of relating. And really, self-compassion can be a really powerful intervention, because you're positioning yourself to be compassionate which allows you to be imperfect, which allows you to continue to keep trying, as opposed to heavy judgment, which makes us all want to get back into bed and cover our heads and never come out.
Mhm.
So that was a big
Right, that was great. What I really appreciated about the book is you give some personal stories
Mhm.
about yourself. And what I always think is great about that is people can really relate to the personal stories. So I was that was fantastic. I got a question that came in,
Mhm.
and ask it.
Yeah.
How does one with anxiety know the difference between physical symptoms, which are a result of anxiety, or actual ailments or illnesses? And this person Googles for hours with worries sometimes about what if I have this or what if I have that. I think this is a really uh,
Yeah.
common activity people do.
Yeah, the Google, Dr. Google is a real phenomenon and a real
Yeah.
problem. When I was little, all we had was encyclopedias. So like there
Mhm.
was an end to it. They had a
Mhm.
section and that was it. That was all you could get. Nowadays, you can find, so much and it never ends and it's available at all times.
Mhm.
And so the answer to that question is there really isn't one answer for that. The first
Mhm.
thing is the language of knowing. We all love the idea of knowing, but there is very little that we can 100% know. And what happens, especially with health anxiety, is it feels like you should be able to know for sure whether or not you have some kind of neurodegenerative illness or cancer or something like that. And the truth of the matter is knowing 100%, which is what anxiety demands, is not really an option. Now, in the book, though, I do give some ideas and some guidance around that because it is possible, and it happens a lot, that you can have symptoms and they are real and they are happening. It's just they don't necessarily mean what you think they mean. And that ties back to what I just said about this idea of where do we get the idea that we shouldn't experience things in our bodies? We have this idea that they should be a certain perfect kind of way. And so, I think understanding that piece, but like, how do we know the difference between when a physical symptom is something to attend to and when it's not? And, you know, so I'll give you my all around answers to those things. The first being that I encourage anyone I'm working with that has concern about their health like this to first things first. Have you been to a doctor? Are you doing the things that we do to keep our bodies healthy? Right? One like a doctor. I don't mean like 50 doctors. I mean like have you gone to a doctor? Have you been following what the doctor suggested? So I always want to start from there because there's a lot of people that have really um, been hurt by professionals who misunderstand and health anxiety. And so you never want to give someone the idea that it's all in their head they're experiencing this. You're experiencing it. It's just, do I need to attend to it? So I always start with the doctor, and then after that, following doctor directions. And then after that, when you're experiencing a symptom and you're anxious about it, I always ask people to check in with themselves and and look for urgency. Do I feel an urgent sense that something absolutely has to be done right this minute and I couldn't go another minute without knowing? And is it repetitive, like showing up over and over and over? And so, in those cases, if that's what's happening, you don't have any perspective of what's really going on in our body, right? And if you're so embroiled in anxiety and you're Googling and Googling and Googling, you've kind of you've got the computer and you've got your face and you're right here. You can't see anything because you're too close. And so the first move is, am I feeling urgency? Am I feeling a need to know? Am I feeling like this thought shows up over and over? If so, first things first is to sort of recognize that that's what's happening, and, trying to allow that to be there for a period of time. Sometimes I'll talk with people about like timestamps, so like, okay, so like, how about we take this concern, this worry you have about your body, and we imagine we put it in a box, and we take this box and we put it up here on the shelf. And that doesn't mean it's gone. It's going to talk to you and it's going to be like, hey, what about this thing? And what
Mhm.
you're going to do is you're going to say, I'm not doing that right now. I'll attend to that on, October 18th,
Mhm.
72 hours from now. And every time I think about it, I'm going to say, we're not doing that now, which the hope of that is to have a little bit more perspective because you haven't been ruminating for hours and hours.
Mhm.
You haven't been Googling. And during that time when you've put this worry on the shelf, you're like, I'm asking people to stay off Google. I'm asking people, to stop reassurance seeking and doing those things. Now,
Mhm.
obviously, if you're a person that's struggling with this for a long, long, long period of time, you know, like this workbook is meant to be like an assist, but not to be the primary intervention. And so, if you've been Googling for, 5 hours a day, me saying, put that in a box and, don't think about it, isn't going to be enough. You have
Mhm.
to decrease. So sometimes I'm working with people to decrease their responses, but I never want to play doctor. I'm not the doctor. What I will do is help people to determine, based on their experience, what are reasonable guidelines for when I need to go to the doctor. Like, and depending on the person and depending on what's going on with them, we'll develop a list that helps in those moments to go, okay, well, is this happening? No. Is this happening? No. Is this happening? No. Okay, so I can put this aside for now. Um, but I never want to be deciding for my patients whether or not they're sick or not. I'm
Mhm.
wanting to help them relate different to the worry thoughts about it.
Mhm. Yeah, what's interesting, and I'm sure you have heard this, uh, those of us who have OCD, we want to be 100% certain. And
Hmm.
if there's a 1% chance, that is enough, right? That is
Yeah.
enough for us to Google, to research, do whatever we need to do. And it's impossible, right, to reach that 100% certainty. It's just impossible. But
Hmm.
OCD, that's a challenge. We have many questions coming in for
Okay,
you.
great.
And so this is actually a pretty common one. How do you shut down your anxious thoughts? I have problems sleeping because my mind seems to never shut down. I'm sure this is a really common one. So, how would you go about explaining helping
Yeah.
somebody like that? That's a big one.
Well, I mean, I would first start with just like empathizing and validating, like that is
Hmm.
a really difficult thing. And that many, many, many people with anxiety, whether you have generalized anxiety, whether you have whatever your anxiety is, um, has the experience of having a brain that doesn't go to sleep, that doesn't shut down. And so validating and empathizing. And then I tell them this news, which sometimes people don't love, but is true, which is when we want to make something go away or shut down something, that language of like shut it down, we all would love that, right? But the effort to get rid of something is what keeps it coming. So if a person is trying to go to sleep, right, and they're having these thoughts and they're like, oh no, I don't want that. How do I get rid of it? It actually is activating it. It's actually inviting it. So what I usually encourage people to do is practice mindfulness when you're sleeping, when you're trying to go to sleep. A very wise person once told me that with sleep, the most you can really do is show up for it. Now, yeah, there's sleep hygiene and things like that, but the best we can do is show up for sleeping, right? And then, something I do that it's going to sound weird maybe, but like when I'm struggling to sleep, it's often because my mind, I'm like working on something, whether it be work literally or a problem or something I'm worried about. And I'll say, Molly, you're not working. Like you're not working right now. And so then like focusing on the different parts of like if you're laying down and you're trying to go to sleep, you have to kind of make some space for noise. Like, okay, so my brain's doing this. I don't love it. It's happening. I don't have to engage with it. So then is when I usually ask people to sort of anchor themselves to something about where they're laying down and to, like I'll put my foot out on top of the comforter so I can feel the fan on my foot. And then I'm paying attention to where do I feel it on my foot. And so there's lots of ways to do that with like the softness of the sheets or the texture or like the feeling of your body on the mattress, and really trying to get into your sensory experience can be really valuable in going to
Mhm.
sleep.
Mhm. So just change the subject a little bit.
Huh?
Question came in on the difference between appearance-based obsessions
Yeah.
and body dysmorphic disorder. I know that's a big area, and you talk about that in depth in your book.
Mhm.
You go
Yeah,
through that a little bit? Yeah.
sure. So there's a reason I differentiated with those. And there's a couple reasons. One is I frequently see people that have OCD or generalized anxiety disorder that do have some type of anxiety about their appearance, or they might have, like, I don't like how my nose is shaped, or I don't like how my stomach looks in these
Mhm.
pants. And it might be even causing a lot of anxiety and making them do things like change repeatedly or check in the mirror. But they don't meet the criteria for BDD. And instead, it's more like to me, it falls under the category of, OCD or appearance based. And that's why I called them appearance based, because you can see
Mhm.
those in other disorders besides BDD. I put BDD on its own chapter and also did not, I did more of like an introduction to what BDD is, because I wanted to really emphasize that if you're struggling and if you have BDD, it can be incredibly debilitating, incredibly painful, because people that have BDD are filled with like shame and self-loathing. And there's a belief they have that there is some aspect of their appearance that is defective or flawed. And it is so extreme that they often refer to themselves with language like monster, horrendous, ugly, which is a level above, I would say, appearance focused obsessions. And so because with BDD, and I'm not even giving enough justice to BDD because it really is a disorder that requires specific treatment for BDD. I think some of the tools are helpful, but I think you need treatment, especially because there's a higher risk of suicide in BDD, and the other things I put in that chapter, misophonia um, and the things that are in that separate
Mhm.
chapter. So that's how I differentiate. It's really the severity, it's the belief. A lot of times when somebody has an appearance based, they don't have BDD, they don't think they're horrible looking, or they
Mhm.
don't think that everybody else thinks they're horrible looking per se. And it's not usually like dominating every aspect of their life. In BDD, there's, constant checking every type of reflective surface, and, just there's a lot more that goes into it. Maybe like sitting in a certain spot so the light doesn't hit you in a certain way. It's yeah. So that's why I was careful to differentiate those.
I, for one, appreciated the explanation of appearance-based obsessions. And just self-disclosure, I suffer from that, but it doesn't reach the point of BDD. But I
Mhm.
think some people think that they may have BDD, but it's not. It's just they're really focused on their appearance and challenges with that. So great explanation in that. I have another question
Yeah.
that came in. So this is from a parent.
Okay.
What's the best way for a parent to help an anxious teen or young adult in the moment when they are having, and they're saying out loud, a body brain intrusive negative thought about themselves? Any thoughts
Yeah.
on that?
Yeah. I mean, I have a lot. I have a lot of thoughts. We're talking
I
about
love
parents,
it.
so I'm
Love
having
it.
a lot of thoughts. I mean, there's so much. You know, when parents ask these questions, the first thing I always want to say is your mom and dad, not the therapist. So I think the answer depends on whether this child is in what their teen is in treatment or not, whether or not they have received psychoeducation about responding to these kinds of intrusive thoughts. But I would say, without knowing the case, that what can go a long way is simple. I see your suffering, and the desire to want to be helpful. If they've had some psychoeducation, then they know telling the person that they shouldn't worry or it's not a problem is not helpful. So that's why I always start with validation. I always start with, you know what, like this isn't like if the child wants to talk about whatever it is they're anxious about, or they want to talk about how they look, and they're trying to get reassurance, I would encourage parents to say to them, look, honey, like I love you, and I see you're suffering and I want to help you, but this isn't really helpful for me to give you reassurance. It actually makes you worse. So usually offering to do something else with them. I'm not going to talk about that, but hey, what if we go watch your favorite show? Or what if we go for a walk? Just kind of validating what you're seeing, empathizing, and offering support that's not reassurance.
That's great. And the thing about this subject is we have um, all kinds of questions coming from all
Yeah,
different areas. So I'm kind of going back and forth on some of these questions.
I'll try
And
to
this is
answer them quickly so that we can get
you're
to
doing
more.
great. Awesome. This is a question about why. Why does someone suddenly develop anxiety or fear? For example, fear of driving on the highway,
Mhm.
a highway they've driven their whole life with no issues. And all of a sudden, they get this fear, anxiety, fear that they're going to, go off the edge or something bad's going to happen.
Mhm.
What's your thinking on that?
A lot of thoughts about that. Um, Oftentimes, when I hear things like that, there's a couple things that come to mind. One is usually the person has had some other symptoms at some point in time in their life that perhaps they didn't identify. So, like when I'm doing an assessment with somebody and we're going through lists of like common behaviors, common worries in OCD specifically, they'll be like, oh, I didn't realize that was a symptom and that was a symptom. So, it's possible that the person maybe did have some anxiety that they just didn't necessarily notice. Um, or it wasn't problematic to the same level. The other piece is, was there a trigger? Was there some kind of really stressful life event, right? That might have been not related to the accident, to the driving, but could be, right, really stressful. And if they had a predisposition to be anxious, there's that. Now, the last example, which happens frequently in our practice because we work with complex cases, is if somebody comes to me and they have really not had any real symptoms and suddenly they're doing, they can't drive, they, can't leave the house, and it came out of nowhere. Often I assess for whether or not there's some trauma history in their lives, because what we see with late onset is oftentimes there's a trauma history, and the OCD is something that's serving as maybe a coping skill. And there's a lot more that goes into that, but those are my general thoughts.
That's great. And change subject a little bit. What is the philosophy behind not reassuring your child and telling them you're not going to do it while they're in an acute crisis? Yeah. Big one.
So there's a couple things with that. I'm very mindful when I'm working with parents about recognizing that when you see your child's face suffering and in need, it is natural and normal to want to jump in there and help, right? The problem with reassurance is it doesn't help. And what you'll usually see is that immediately after doing it, they come back to you, right, with something else or the same thing. And it's actually feeding the cycle. So reassurance is something that negatively reinforces the anxiety. Now, in a case like that, not knowing this case, if you're a parent that's always reassured a child, let's just say every night you do like a whole routine where you reassure them, I wouldn't suggest you just go to zero reassurance. That to me is something where you collaborate with a therapist and the whole family to decide how you want to reduce it, with the understanding that it's not helpful. So it's never looking at your child and being like, nope, I'm not doing it. It's more like, if you have a plan to reduce it, you kind of like remind them why you don't want to reassure them, because it doesn't help them. But if you've come up with a plan with a therapist and you're trying to reduce reassurances, then, maybe some reassurance is warranted if you're new in treatment and you're working on decreasing first. But, hugging, saying, I see you suffering, goes a really long way with kids. As parents, we just want to fix, and like, that's natural. It's just that it doesn't work. That's really the big answer. It just doesn't work well. One thing I did want to add really quickly is there is a bonus chapter that you can get access to that is specifically for families. It was going to go in the book, but it was written for families, really. So that is a good resource if somebody wants to take a look at that chapter. It's free.
It's perfect.
Yeah.
It's great. Little bit of a longer question, but I think it's probably very applicable to many of the people we have on here. It's hard to know the difference between a major health concern. You've kind of touched on this a little bit. It's hard to know the difference between a major health concern or if something is more minor when I have a history of major health issues, when seemingly minor symptoms. How do you recommend calming down if I notice new minor symptoms that might potentially indicate something major? Makes me feel exhausted because I'm on alert all the time, trying to notice new symptoms in case something bad is on the horizon.
Yeah. I mean, that's really difficult. And I do work with a lot of patients actually that do have chronic conditions or have complicated medical histories in which they've been told, like, it's really important that that you pay attention to new symptoms. And so it is there really isn't a like a quick 1 minute answer to that,
Sure.
other than to say that talking with your doctor, communicating with your doctor about what to look for, but also letting your doctor know the challenge you're having. A lot of times people feel like they don't want to tell their doctor about how anxious they are about
Mhm.
the symptom. And so then they don't really get the guidance of like, this is what where they can help you weed out the things you shouldn't have to worry about. And then, of course, there's strategies like practicing mindfulness and things like that that can go into the calming down process, is like remembering that there's no amount of ruminating or worrying or Googling that's going to help the situation.
Mhm.
I also would suggest, like, if someone's anxious about a symptom, is I'm having a thought, like I'll tell them to like try to like sort of step back, and instead of saying, this symptom might be cancer, I'll say I'm having the thought that this, change in my heartbeat is going to be a problem. And there's a very
Mhm.
big difference between saying I'm having a thought about it and something bad's happening.
Right.
But it's complicated. And I think it's validating. Yes, you've had medical concerns. Yes, it makes sense for you to be You're just, you might be over attending.
Mhm. I know in your book you mentioned, which along these same lines, that you were maybe tentative about telling the doctor about all your anxieties. And it was when you came forward
Mhm.
and just said, look, I have OCD. This is the challenge. And it was so you got relieved, and it was such a relief for you to come out and say that. So I think you're right. I think a lot of, and myself too, we're nervous, we're scared about telling people about what is really going on, but it's so healthy to do that, and it's so freeing to do that. And I think that
Mhm.
was a really good. I really appreciated that in your book. Another question, from a psychological perspective, is body-based obsession caused more by anxiety around control, depression around identity, or a combination of both? If you could kind of wrap your head around that one.
Yeah, I'm trying to think of how to answer that. I mean, body-based, there's probably a lot of school of thought about what causes them. So maybe read the question one more time.
Yeah, no, from a psychological perspective, is body-based obsession caused more by anxiety around control,
Hmm.
depression around identity, or a combination of both?
I would say I would say it's a combination of many, many things.
Mm-hmm.
I would say that I wouldn't necessarily say that it's about control. Um,
Mm-hmm.
but again, like, this is one of those things that I think the answer is kind of complicated, because we don't
Yes,
really know what causes intrusive
sure.
thoughts, or we don't really know why somebody gets anxious about a specific thing. But then there are times when we do know that it's connected to something in their past, maybe a parent that was sick. Or so I wouldn't say it's an either or. I would say it's a complex combination of genetics, environment, learning. Um,
Mhm.
and it's not a very satisfying answer, but that's
No,
what
you're right. It's challenging because I think we all want to know, um, what causes this, and
oh,
we just, the research is trying to find out, but we
yeah.
don't know yet, right?
Okay, well, here's the voice without a face. I think we have maybe time for two more questions.
Okay. Um, so, Molly, what do you hope readers take away from this workbook beyond symptom relief? What are you hoping that they
I
get out of
mean,
this?
I'm hoping that they have hope that they can actually live a really quality, joyful life, even with obsessions about their body, even with,
Mhm.
things that are coming up in their mind. And the reason I know this is because that's been true for me, and that's what inspired me to do the work I do, is knowing that, like, there was a time where I didn't think that you could get better. I didn't even know there was a treatment. And then to find out, like, oh, I can have like a really good life even if I have a mind that sometimes likes to, go haywire. I have strategies and tools. So I guess hope is one.
Mhm. Mhm.
And also to just like really consider of like, how can I relate to my body in a kinder, softer, gentler way? How can I relate to my mind different?
Mhm. So I just want to, again, reading your book, I want to thank you personally for helping, bring compassion and clarity to a topic that there's so many people that struggle and to put into words. And I think that your work continues to open doors for those of us who have felt invisible
Hmm.
in the OCD community, because these aren't typical, people don't think of OCD in this manner. So I, for one, appreciate that.
Thank you.